Dr. Neeraj Shah.
Yeah. Good afternoon, everyone. So today I'll be talking about a novel foldable acrylic device to prevent posterior capsular opacification. So why did we do this study? So cataract surgery has the potential to improve patients' vision, and refractive error. But with the onset of PCO, patients end up having again loss of vision. So and the treatment for PCO could be YAG cap, which itself may pose a risk in cases of high myopes, can cause RD in those with RD, then in patients with diabetes mellitus. Also, it could result in an iopic spike and cystoid macular edema, rarely IOL damage or IOL dislocation. So we are describing our initial results of hydrophobic acrylic PCO preventing ring implanted during IOL insertion into the capsular bag. So obviously we know that the PCO is caused by proliferation of lens epithelial cells behind the IOL, and which causes opacification of the posterior capsule. How did we do it? Study design, it was a prospective non-randomized clinical case series. It was performed in a tertiary eye care center. Enrollment period was from June 2015 to December 2016. Study cohort were presbyopic ametropic patients in the age group of 45 to 65 years who had cataract. We enrolled 30 eyes of 23 patients. The pre-op evaluation included AR, IOP evaluation, uncorrected and best corrected vision, near vision. Biometry was done, anterior segment evaluation and dilated fundus evaluation. IOL power targeted was minus 0.5 diopters myopia to compensate for the posterior IOL displacement. A single piece hydrophobic acrylic foldable 13 mm IOL was placed, which had an optic of 6 mm. The post-op evaluation was done at 1 week, 1 month, 6 months and 12 months. The ring is a foldable hydrophobic acrylic material with an outer diameter of 9 mm and an inner diameter of 6.5 mm with a thickness of 0.4 mm. It can be implanted via a regular 2.4 mm incision using a conventional IOL cartridge and an injector. It fits into the periphery of the bag irrespective of the size and shape of the anterior capsular axis. It strengthens the capsular bag and providing excellent IOL centration. It also prevents IOL tilting. The ring is implanted over the IOL after the placement of the IOL during the surgery itself. So this leads to posterior displacement of the IOL and opposition of the IOL against the posterior capsule. So what we did was we did it in 30 eyes of 23 patients. The mean follow-up was recorded as 15.5 months. Mean patient age was 55 years. There were 16 males and 14 females. IOL power calculation was done with SRKT formula with an accuracy up to plus or minus 0.3 diopters. Post-operatively, all patients had a well-centered IOL within the bag and a normal anterior chamber. So these photos describe the centration of the IOL. There's no tilting, no PCO, no folds. So the outcomes were all 30 eyes had a BCVA of 20/20 and near vision of N6 with distance correction. Uncorrected vision of 27 eyes were 20/30 or better, and remaining 3 eyes had 20/40. All the patients were highly satisfied with their subjective visual quality. No PCO was observed until a follow-up of 18 months. Adverse events noted were 2 patients developed intense inflammatory reaction in the anterior segment in the immediate post-op period. They were treated with hourly topical steroids, but we were not able to determine the source of uveitis in those cases. So we conclude that the future is now a PCO preventive device. It's a 360-degree square edge profile of the ring facilitated the creation of a sharp equatorial bend in the capsule. This hindered lens epithelial cell migration. It offers the perfect solution in preventing PCL and achieving IOL positioning in cataract surgery. Thank you.
Thank you, doctor. I think this particular device, where you want to, like if you are having subluxated cataract, you put it, or every case you are implanting?
In fact, we could use it in both the cases. In every case so as to prevent PCO, and in obviously subluxated cases, it can work as a CTR.
See, nowadays you have seen most of these IOLs available in the market. They come with a sort of a sharp square edge pattern, so that itself will prevent the migration of epithelial cells, and that prevent PCO. So especially higher end lenses, imported lenses. See, whether you put it in a Indian, the patient already operated with the Indian IOL, or whether you put it for every patient, whether it is higher end or
Actually, we have not segregated our patients in that manner. Our perspective is that irrespective of the lens, whether the IOL has a sharp edge posterior, side profile and all, if you implant it in every case, that could just eliminate the formation of PCO.
There are two issues can happen. See, once you put one more implant over the present IOL, the biometry may change. Possibilities are there. One.
Yes.
Especially if you are really planning for something like multifocal intraocular lens, then that may change. And the pattern of the IOL, some of the IOLs comes in a C loop, some of the IOL come in 4 haptic. So what is your overall inference regarding different model type of IOL?
Yes, so we've until now done only with C loops.
C loop.
So obviously we'll have to do with these and determine whether different types of IOL designs, how does it influence the outcomes.
Okay, thanks.
Don't you think that the posterior segment is too bulky? Can it lead to glaucoma later on? Did you have any case of glaucoma or pigment release? Because it is in direct contact with the posterior part of the iris or the pigment epithelium of the iris.
No, sir, we've not observed any such.
Do you think that it can cause later on glaucoma? As
No,
Dr. Kudlu has very rightly mentioned, all the lenses are, mostly the lenses are of square edge except for the plate haptics.
So perhaps if the anterior segment is very shallow, it could cause rubbing with the iris.
Lens is out, then there is no question of swallowing or. I'm just asking, posterior segment is too bulky. Like we say that when you use hydrophobic lenses with normal haptics, we don't use in sulcus, we use 3-piece lenses just because of this, because we don't want to make it very bulky.
Yes, sir.
Right, and sometimes it can lead to ciliary body rotation as well. So do you think it can happen? No.
We have not noticed it, but
okay.
But potentially.
Overall,
good
this concept as like sort of a piggyback lenses. So piggyback, have you heard about piggyback lenses, where we used to put a 2 IOL? Have you seen any of the complication in your case study? Have you found, of course, it prevent PCO. Have you seen any time of in your case electronic microscope examination find out any migration of cell in between your this
device
and the lens?
So the device is within the bag itself, so it will be in the periphery, and it will push on the haptics such that the optic gets opposed to the posterior capsule. But no, we've not done any electron microscopy study.
Good presentation, of course. Good innovative by my friend J.K. Reddy.